continuing the brainstorming on cardiovascular training. And our first speaker is Dr. Herschel Schaff from the Mayo Clinic, addressing the importance of research and training of thoracic surgeons. Thank you.
Well, thank you. My assignment is to discuss research and training of cardiothoracic surgeons. And if I can get this to work. The other way. Perfect. All right. Thank you. So there's no disclosure, except I'll tell you this is mostly opinion. It's highly personal. It's my experience. And I'm going to avoid the really important issue, the elephant in the room, and that has to do with funding of research. Maybe we can talk about that at the discussion period. Now, I took a brief survey of the surgeons from North America who were supposed to be here, and obviously they couldn't come because of the concern about the virus. But of the 14 surgeons who were trained in the United States who were scheduled to speak at this meeting, 11 of those surgeons had dedicated research time during their residency or before their residency. Of the 11 surgeons who had dedicated research time, 8 had programs that were 2 years or more, and some had PhDs. And the fields of study are widely varied. I mean, if you look at thoracic surgery, thoracic with a big T, that includes general thoracic surgery as well as cardiovascular surgery. These surgeons had training in studies on myocardial protection, integrated cardiac physiology, electrophysiology, molecular biology, cancer immunology, transplantation, and pathology. So there's a wide variety of research experiences that surgeons have. For example, Ralph Damiano had his research experience with Jim Cox when he was a resident at Duke, and he continues to do studies on atrial fibrillation. So his research experience during residency carried over into his practice as a mature surgeon. Others, and I suspect most surgeons who do research don't continue on with that line of investigation when they become staff. For example, Thor Sant, when he was a young surgeon at the National Institutes of Health, studied transplantation, and now he has an interest in aortic disease and patient safety. So the research experience is not to direct or dictate what your ultimate career goal is. Likewise, David Adams, when he was a young surgeon, studied in pathology at Harvard, and he was studying graft atherosclerosis. Now, of course, as everyone knows, he has an interest in mitral valve disease. So let's think about the domains of research and what's available. We discussed some of them when we looked at the surgeons who had come to this or were scheduled to come to this meeting. But the obvious ones are molecular, cellular biology, and immunology, and integrated physiology, which we don't have access to as much. I suspect most programs don't have as many large animal laboratories now as was true 30 or 40 years ago. But there are some new areas that need to be emphasized for our young trainees, and that has to do with device development. Biomedical engineering is a good background for surgeons who are interested in device development, and also the science of outcomes research, both for quality and for patient safety. So these are newer areas that young surgeons could receive training in and could have a research experience in. Now, why should we emphasize surgery in the training of a young surgeon? Well, obviously there's an opportunity for career advancement. In some cases in the United States, if you want to get a residency in that particular program, you have to do a year or two of research with the professor. And that's okay. I think that's a reasonable reason to go ahead with research, a very practical reason. It also prepares you for an academic career, because what you learn as a research fellow may be a springboard for subsequent funding opportunities when you become a staff surgeon. So it helps you prepare for an academic career. But there are other reasons to do research in training, and that's because up to the time when you were a medical student in your first 1 or 2 years of surgical training, you're a generalist. You're learning as much as you can about as many things as you can, and it's a very, very broad education. When you're doing research, you're reflecting on and exploring usually single topics and single areas. And I think this is very helpful for somebody who's been for 4 or 6 or 7 years having a general education in medicine. You develop expertise. When you're a second year or third year resident in surgery and you aim to be a cardiothoracic surgeon, no one is going to invite you to a meeting to talk about tetralogy of Fallot. But what you do in the research laboratory, you can gain within a year or two enough experience and do enough studies that you become an expert in that area, and then you'll have an opportunity to share what you've learned. It also gives you formal scientific education. Now, in the past, when a resident went into the lab with a mentor, often they were just assigned to a surgeon and you did your time, worked in the lab. We've always felt like it was important for the surgical fellows who come into our research laboratory to take formal classes in the graduate school, whether it's in graduate school of biomedical science or whether it's in outcomes research. They get, if they're doing clinical research, they get additional education in statistics and epidemiology. They all participate in a program that we call the certificate program. If they stay for 2 years, they can get a master's degree. So it's very important to try to get some formal scientific education during your research experience. You also, as a research fellow, have the first opportunity to learn how to write papers, grants, abstracts, and give presentations. It's interesting that we just assume that if somebody stays in surgical training for 5 years or 7 years, that at the end of that time, they'll know how to give a good presentation. And that's obviously not true. You can pick it up, that's true, but I think it's important, it's an important component of a research experience. Now, when should a resident in their training program go into the research laboratory or have a research experience? My recommendation would be to do it as early as possible after a commitment to thoracic surgery. Now, many surgeons have done MD, PhDs before they go into training, but I think that your research experience will be more pertinent to your subsequent career if you do that research after you've made a commitment to cardiothoracic surgery. Now, this issue of doing it early in residency is important because I've had over 40 residents or fellows in research who spent 1 or more years doing research with us, and there have been only 2 who have come to learn about research after they completed their training. And the reasons are very practical. When you're early in your residency, you're at a point in your life where your family is small, you may or may not be married, your income, your lifestyle is adjusted to your income. When you're finishing your residency, you're anxious to get out into practice and to try what you've learned on a clinical platform, and it's very difficult for surgeons then to go back and spend 1 or 2 years in the laboratory, and probably it's not appropriate to do once you've sharpened your skills as a clinical surgeon. You need to go out and do clinical surgery. So my recommendation would be to do that as early as possible after a commitment to cardiothoracic surgery. Now, to be fair, one of the surgeons who came back and worked with us in the laboratory was one of our most productive fellows that we've had, but I think he is an exception rather than the rule. Now, there are a couple other whys that I'll get to. And these are a little softer. The other advantage or reason why to go in the laboratory is that your relationship with your mentor is often much closer than it is in the clinical arena. You work with that person. You may have weekly or biweekly meetings with your fellow if you're a staff surgeon, and as a fellow you become closer to your mentor. It's also a time that you develop networking. In other words, when you present at meetings as a young fellow, you see other young surgeons who are doing the same kind of work, and those relationships stay with you throughout your career. And then there are what I'll call unanticipated consequences, and this is the personal experience that I'll share with you. There are unanticipated consequences of research. In my case, as a surgeon, I worked with Vince Scott and Tim Gardner in Baltimore, and at that time, the hot topic in cardiac surgery was myocardial protection. So we had an active laboratory looking at various techniques of myocardial protection. We used an isolated heart model to sort of screen cardioplegia solutions and different strategies for protecting the heart. And it was an interesting time. It was an interesting preparation. We actually could measure intramyocardial oxygen tensions, and we could measure function quite accurately. This was done with an intraventricular balloon in a beating cat heart and an asynchronously perfused model. And one of the early studies just looked at the influence of hypothermia and cardioplegia, something that we all use today. We cool the heart and we arrest the heart with potassium cardioplegia. And this was one of the first studies that we did in the laboratory that showed that if you cool the heart, you have better function after cardiac arrest than with normothermia. And if you cool the heart and give cardioplegia, you had the best results. So it's something that we all take for granted, but it wasn't known at that time particularly well. And this just is another way of looking at systolic function and preservation of systolic function with cold potassium cardioplegia. But what we noticed in this isolated model was that the hearts that had the poorest systolic function also had the highest end-diastolic pressure. So after arrest and reperfusion, if you put the same volume back into the ventricle and you reperfuse the heart, then you have an elevation in the end-diastolic pressure. So why is that? Why do you have an elevated end-diastolic pressure in an isovolemic model? The hearts that were best protected had the best function and the lowest end-diastolic pressure. And this just shows the end-diastolic pressure during reperfusion in two groups, depending on the length of reperfusion. Now, what we found in the isolated heart model was that the amount of increase in end-diastolic pressure was related to the water content. And so that suggested that the hearts were becoming edematous. And we studied that a little bit further, looking at pressure-volume relationships. And if you look at the end-diastolic pressure-volume relationship, it's exponential. And in hearts that had the highest end-diastolic pressure, they had what we called, or we all call, stiffer ventricles. But is it really stiffer? And it turns out if you take the logarithmic, transform the curve to a logarithmic curve, that the curve is shifted to the left. So you have a higher pressure at any end-diastolic volume, but it's not because you have increased muscle stiffness. It's because you have a smaller ventricle from edema. And that kind of made sense. And we thought that was an important observation 30 years ago. Now, let's fast forward. Fast forward to a point where we're managing patients with hypertrophic cardiomyopathy. And in most patients, when I began work with hypertrophic cardiomyopathy, had subaortic obstruction, and we were very careful to select patients that had this isolated basal septal hypertrophy. But this phenotype is a relatively small proportion of patients with hypertrophic cardiomyopathy. And it turns out that the majority of patients don't have isolated basal septal hypertrophy. They have more diffuse hypertrophy. And in Asia, for example, apical hypertrophic cardiomyopathy accounts for about 25% of patients, and that's shown in panel F. Now, most patients with apical hypertrophic cardiomyopathy are asymptomatic and don't need anything done. But once they develop heart failure, they're very difficult to treat. And the reason they're difficult to treat is there's no solution for reducing the gradient. They don't have a gradient. They have a high end diastolic pressure. But why do they have a high end diastolic pressure? Is their muscle stiffer? Is it thicker? Or is the chamber smaller? And it was Rick Nishimura who, when one day we were looking at cases that we thought might be candidates for septal myectomy, and Rick showed me a case of apical hypertrophic cardiomyopathy. He said, it's too bad you don't have an operation for this because these are very frustrating cases to manage. And I thought back to the time when we had small ventricles due to edema, and you can correct the edema by giving mannitol or hyperosmolar perfusion and reverse the edema. And as a surgeon, when you look at the problem of ventricles that's too small, the surgical answer is to enlarge the ventricle. And that's how we started on this program of left ventricular enlargement for patients with hypertrophic cardiomyopathy. Now, does it work? Yes, it works. This is the end diastolic pressure volume relationship, and on the right you can see the formula. And what's in light blue or green there is the alpha constant, and the alpha constant is the slope of the line. And you can see that at any end diastolic volume, that curve to the left has a higher end diastolic pressure because the alpha constant is changed. That's stiffness. But you can also have a higher pressure at any end diastolic volume with a change in what's called the beta constant, and that's the unstressed volume of the ventricle. So here you have not a shift upward in the curve, not an increase in muscle stiffness, but an increase in chamber stiffness because it's too small. Now, after we did the first patients we did the apical myectomies to enlarge the ventricle, we did detailed hemodynamic studies. This is one of the caths that Rick Nishimura did for us. You can see on the left there is a patient who had an elevated left atrial pressure, the same patient after surgery with the same LV systolic pressure as a lower left atrial pressure. And when we looked at these in aggregate, we saw that there was a significant decrease in end diastolic pressure in the patients after apical myectomy and ventricular enlargement. And there was a significant increase in left ventricular end diastolic volume by ventriculography. Now, as surgeons, we're not used to looking at pressure volume curves, but this is a pressure volume curve of a patient with apical hypertrophic cardiomyopathy. And if you just imagine if the operation works, how should this change? Well, it should change. We should increase the stroke volume and lower the end diastolic pressure. So this is the patient before left ventricular enlargement, and this is the same patient after left ventricular enlargement. You can see that the stroke volume is increased and the end diastolic pressure has decreased. So I consider this an unintended consequence of a research experience that I had, and I suspect that many other surgeons can look back and reflect on the experience they had as research fellows and think about how that might tie into their current practice. The take-home points, I would say, that I didn't talk about the challenges we have for funding and for time, but those are obvious issues that need to be discussed. I think that research adds value to the trainee, it adds value to our specialty, and as I mentioned, it may have unanticipated consequences. Thank you.
I think we'll have to take all questions at the end of the session.
Pardon?
We'll take the questions at the end of the session. Thanks very much.
Thank you, Dr. Shah. The next speaker is Dr. Smith, and I think it's just a natural progression to talk about integrated interdisciplinary simulation program, an essential addition of cardiovascular and thoracic surgeons. Dr. Smith.
Good morning, everyone. Thanks. I just want to thank the organization for asking me to talk about our program. Where we're developing a multi-center integrated interdisciplinary simulation program, which we described in an editorial earlier this year in the European Journal. In the interest of time, I'm just going to concentrate on a number of important issues, and that is, I think that simulation programs, in our program, we're aiming at proficiency, not a competency program. And simulation programs, as an adjunct to existing training programs, should address the holistic development of a surgeon, but also not only of a surgeon, but as the whole team. It should address human factors and systemic management training, as it involves, it is involved in 70% or more of complications, preventable complications, failure to resuscitate and preventable deaths, and it determines the functionality of the team and patient safety by implication. An ideal program should address the transfer of knowledge through appropriate education and learning systems, and also address the development of an appropriate and reproducible surgical skill set in a safe environment. Proper and clear assessment systems and structures after each exercise with proximate feedback must be in place, and ideally it has to evolve to workplace equivalent assessment for both the individual and the team. And importantly, it has to be repeated until proficiency is achieved. Now, if we just break this down in a number of issues, the first component of our program is to present a non-technical skills surgeon or NOTS the program embedded in the course. And that really looks at the airline industry that over the years developed if you can see this massive decline in fatal accidents, is basically results from the establishment of crew resource management programs within the airline community, addressing communication, decision-making, team building, workload management, and situational awareness, as well as a solid grounding in risk models, risk modulation, and risk management. And this then leads on to systems approach for safer surgery, where the patient risk factors are identified, and then systematically individual skills are addressed, treatment, teamwork and communication, the operating environment and procedures, organizational context within your specific hospital and institution, in order to integrate all of that into clinical processes that would benefit patient outcomes and make the whole procedure safer and more predictable and also reproducible. The philosophy we've adopted is to emphasize the role of deliberate practice in the acquisition of expert performance. And this is really based on educational philosophy and work that was done by psychologist Anders Ericsson many years ago in the 90s. And I think the important point is that he emphasized that the individual differences, even amongst elite performance, are closely related to assessed amount of deliberate practice. And many characteristics once believed to reflect innate talent are actually the result of intense practice extending for over a period of time. And I think that we all watch successful people, whether it's sport, high intensity activities, and what you see is the success. What you don't see, and I think that everyone recognizes that what you don't see is the dedication, hard work, discipline, the disappointment, the sacrifice, the failure, and the persistence in order to achieve that level of performance. Now, if we look at the creation of simulation programs or education programs, it's basically two things that we have to transfer. The first thing is knowledge transfer, and the second is a skills transfer. And we believe that the blended learning model is the obvious, it's the buzzword nowadays, but it's also the obvious way to go. Just because of the way people think, interact, and retain knowledge, And if you look at what happens if you have a lecture, well, like we have today, you probably remember nothing about it in a day or two. So, and as you use different modalities in reading, audio, visual, demonstration, discussion, practice performance, and teaching others, you increase the retention and understanding that the learner achieves in the process. Sorry, it stopped working. Oh, sorry, there it goes. In terms of skills requirement, we use a metric-based skills transfer method, where every step is described in great detail, so that we know exactly what is expected, and the candidate also knows step by step what is expected in detail. I think it's also important just to spend a moment on discussing attention capacity. We have to realize that attention capacity for all humans is finite. Workload for the brain of a novice is actually significantly higher, and the experts will leverage less cognitive capacity and actually paradoxically find it easier to learn. And in the simulation programs, we are trying to introduce a continuous learning principle in the way of pre-training, so that the cognitive load of the novices can be preserved. And this specifically also has an impact on high stress environments. So if you look at this graph here, this shows what happens to a novice surgeon. He spends a lot of time on psychomotor performance, depth and spatial judgment, operative judgment, comprehending instructions, and then, well, that's the end of his attention span, and he actually achieves very little knowledge out of a surgical exercise, whereas the master surgeon, who've integrated this over a period of time, has a tremendous reserve capacity to learn and to actually think. Now, by stepwise pre-training, it has clearly been demonstrated that you can lower the attention spent on tasks by the novice surgeon, and actually bring him back into attention capacity threshold within which he can actually learn and progress. And I think that's an important aspect, and especially in a high stress environment where anxiety might play a role, this is more important. So if we look at what we're doing, we're basically looking at the transfer of skill, the transfer of knowledge, facilitation of insight, then the facilitation of the ability to execute the correct decisions effectively, and eventually facilitation of the ability to integrate all the variables of a clinical picture and make decisions. And that basically takes us from the novice level to a proficient or expert level, not only a competency level. Just to briefly give you an idea of what we are doing, we have an integrated interdisciplinary simulation program where we have a virtual outpatient and diagnostics imaging and ultrasound setup. We're addressing human factors in the course, allied health training, specifically transfer of basic surgical skills with dry and wet bench models, sim boxes, and virtual reality thoracic simulation. We have a virtual cath lab where we can look at wire skills, and a virtual OR where we have a beating heart model and can address also issues related to cardiopulmonary bypass, ECMO, VAD, and also interaction with operating room personnel, including anesthesia, ventilation, and ICU management. So what we've designed is a 2-year hub-and-spoke multi-center modular course, obviously aimed at the South African population, and mainly so we have all the training units involved, and the course is intended to start with a 3-day introduction course, 1 day NOTS, background in educational theory and practice, introduction to basic cardiothoracic surgical skills, and basic sciences for cardiothoracic surgery, and then that also includes an assessment and feedback as applicable. Now, if you look at any module, as it is a modular course, we call it Module X. These are two components, a knowledge component and a skills component. So in the process, the subject would be introduced by an expert, and the aims and objectives would be explained. And in the theoretical module, there will be a NOTS component or a systems component. The education component would be explained. The knowledge transfers would happen through blended learning, and there would be a theoretical assessment which the trainee have to pass in order to progress to the practical exercise. In the practical exercise, it's a demonstration video by an expert or a reference site. The objectives to be obtained and the assessment that will happen is explained. The simulation exercise would then be conducted, evaluated on the OSAT system, which I think you're all familiar with. It's objective structured assessment of technical skills. It's possible to upload a video of the exercise if the exercise can't be evaluated and assessed on site. And assessment and feedback would either then be local or by a trained trainer, or it can be referred to a central committee. It's important to repeat the theory and skill set of Module X, or the specific module, until proficiency is achieved. That implies that the theoretical aspect as well as the practical subset have to be repeated repeatedly until a level of proficiency has been achieved. The University of the Free State Simulation Unit supports these activities regarding equipment that might not be available at every training institution, which might include TEE and echo simulator training, virtual reality, VATS training, or specific workshops and relating to perfusion and ECMO and imaging. And finally, we have the high fidelity simulation setup, the Califia beating heart simulator, based in at the University of Free State in Bloemfontein, South Africa. And this then allows us to do high fidelity deliberate training exercises, for example, cannulation, low cardiac output, bleeding, dissection, air emboli, off-pump coronary artery surgery, and so forth. And then we could also, in the next phase, have high-fidelity integrated interdisciplinary scenarios where we can conduct deliberate exercises, for example, aortic arch, ascending aorta, procedures like a Bentall, and scenarios around that. And then it also finally allows us to do workplace assessment where we can have unknown scenarios. And in that process, we can assess knowledge, skills, decision-making, and NOTS aspect of the trainee's development. This is all backed up by an app that's we can download on the candidate and everyone involved can download on their smart devices, smartphones. And it contains the individual data of the trainee and personnel. The course and training material is available on that. We developed it around mentor and champion-driven modules, which means that every expert in the world can actually participate if we invite them or on a volunteer basis. It's possible to create interactive master classes for a wide audience on the web. And it also contains the assessments and the history of assessments. We provide, through the app, objective and proximate feedback. And it also serves as a monitoring and quality control tool. And obviously, it allows for research and development in this field. We believe that this interdisciplinary multi-center tools will become important in the future for most training programs, and could especially provide an important training tool in resource-limited training programs, as well as in areas where there's a lack of standardization, and hopefully that would improve not only the output and the quality of the trainee, but add to the help to create a safe environment for the patients. Thank you very much.
I guess we'll continue the question later on.
The next speaker is Dr. Moon, who's talking on the talk is addresses surgical versus transcatheter skills for future cardiovascular and thoracic surgeons. How to prepare.
Thank you. I was asked to talk about surgical versus transcatheter skills for our future cardiovascular surgeons. I'm trying to figure out which one's which. The arrow? I thought I'd just change the title just a little bit to surgical and transcatheter skills for future cardiovascular surgeons, including our residents and young surgeons. Oops, wrong place. Okay. Sorry. I think a lot of our senior surgeons knew about this. This is just a little comment that was Dr. Mack and several surgeons made in 2011, indicating that when they looked at the TAVI program, the train has already left the station and it ain't coming back. We just need to catch up and get on it with this. We don't want to be the picture of surgeons riding at the back when the cardiologists are leading the ride. So let's backtrack a little bit. And I was also part of this when I was introduced of TAVI by, I guess I could talk about the company. Edward showing me this is what TAVI is going to be in future. And I was actually a little scared in a way personally, but appalled that they actually didn't tell us this to the surgeons, just to the cardiologists initially. But when the TAVI came at the beginning, many surgeons, including me, said that, you know what, it wouldn't be lasting very much because of a lot of complications, including stroke, vascular complications, paravalvular leaks, etc. And then when we start having it stay, we looked at the high-risk trials and say, surgeons think that only the high-risk patients will need TAVI. Well, that wasn't so. We know that we're doing it regularly on intermediate patient groups now, intermediate risk group patients. And now we talk about and say low-risk patients are always going to be there for surgery. Ironically, there are many people who's touching the low risk, and now we start talking about, well, it's the durability of our surgical aortic valve replacement and the prosthesis. Not quite sure. We need to get on that train. So as I said, it's not only about TAVI that we talk about in aortic valves, but now there are advancements in mitral valve surgery, tricuspid valve surgery, how to look after the left atrial appendage. Ascending aorta has not been touched yet, but it's coming, as the descending and the rest of the arch is being touched, and including left ventricular outflow tract and HOCM surgery, etc. And I think for our future cardiovascular surgeons, young and the trainees, we need to acquire the endovascular wire and catheter skills as an essential part of our program. There has been increasing, as you know, there's been increasing demand for TAVI and the like. And as I mentioned, it's going to be exploding into also the low-risk patients. I mean, none of us really want a big incision in the chest. And emerging percutaneous therapies in other areas like mitral valves and tricuspid and et cetera are coming, and it's going to stay. This is a chart that I borrowed from Dr. Mack when he presented this at the end of November of 2019. And if you look at it, year to date from 2012 to 2019, year to date in November, there were 674 TAVI sites. That means that we're losing that much volume in the surgical area. And as far as the TAVI procedures in the United States is concerned, in 2018, You could just look at that number of 63,000, and although we don't have the data, we're estimating that maybe perhaps up to 75,000 TAVI procedures were done in the United States alone. And the mitral clip and volume equally is expanding, as you can imagine, from the early part of 2000 to 2010. I think surgeons are unique apart from the cardiology trainees, and we actually still have the advantageous position to offer the full spectrum of therapy for structural heart disease, and this is what I would like to put that idea into our trainees and the young surgeons, that we could be a complete valve specialist when it comes to this. Not just open heart surgery. I mean, we need to be basically the best in doing open surgical procedures, but we are there to talk about and be trained for transcatheter. We know that we could do minimally invasive procedures, certainly unique to surgery, and also be available to do complex redo interventions. And I think surgeons are also equipped with the ability to prove complete so-called multi-component or multi-modality therapy in one setting in looking after these patients. And I think it is time for us to own back the disease in entirety, including all options, including the catheter skills. The formalized so-called structural heart disease fellowship program accredited by ASCVTS is literally non-existent in North America. There has been no standardized training programs available for cardiac surgeons or residents to obtain endovascular training out there. And I'd like to talk a little bit about US and the Canadian experience for that. So far, it's been sporadic. The training in the structural heart disease interventions is fragmented in several separate forms for our trainees, unfortunately. As I said, there are non-ACGME postgraduate training programs available. There are Food and Drug Administration mandated industry-sponsored device-specific training courses that we all have probably been involved with. There are on-site device companies presenting with the clinical specialist or the MD proctorships. There are society-sponsored so-called national and international conferences, including live cases and the workshops available, and simulation training, as we heard. Unfortunately, these fragmented programs result in significant variability in training and exposing our trainees and the young surgeons to this. And therefore, it is difficult for surgeons to obtain the full set of required skills. I don't think you could see this very well. These are several industry-sponsored transcatheter training programs out there, including Abbott, Medtronic, Edwards, and Bailey's, etc. And there are society-sponsored transcatheter training programs available, such as AATS or EX-sponsored programs and others, and including ISMICS. For the future, I think the training paradigms must be revised to get all together in order to acquire the endovascular skills, which is paramount, and it should be available in structured and accredited programs. And I think failing to do this as a leadership of cardiac surgeons and cardiovascular surgeons, it will ultimately exclude the surgeons getting involved with these programs, other than few selected senior surgeons and others. There has been the involvement of surgeons declining in TAVI. I know that in 2016, our leaders, including Bavaria and others, have reported and written on 2017 annals that the thoracic surgeons involvement is much getting higher. But in fact, there were 5 other studies or reports coming out of Europe at the same time saying that the surgeon's role is diminishing. And the potential reasons for the decline in the involvement is that there has been more transition away from the alternative access to so-called predominantly transfemoral approaches. Surgeons' lack of so-called endovascular experience to autonomously perform the procedure in its entirety. And the fact is that over 90% of TAVI procedures are performed percutaneously through the transfemoral access. And therefore, there's been declining in surgeons' involvement. Sometimes we just stand there and look after waiting for the complications. And there is emerging evidence that absence of an on-site surgeon and surgical team from the procedure did not increase the TAVI mortality or morbidity coming out of Europe. And it's basically same as having no cardiac surgeons available to do coronary artery bypass grafting, and that the percutaneous intervention of coronary anomaly are looked after by the centers only equipped with cardiologists. I think surgeons must continue to expand their knowledge and experience treating valvular disease, and obviously acquire necessary skills to actively participate in structural heart disease. I know we could do this because when I used to go around and teach how to do endoscopic vein harvesting or endoscopic radio harvesting, surgeons, the senior surgeons, they might as well just give up because most of them just couldn't hack it. But the young residents, all they needed was just 1 or 2 showings, and I guess they were Nintendo generations that they were right up there. And I think we could do this with the surgical catheter skills too. We just need the access to this. And obviously, without even stressing that surgeons performing the transcatheter interventions must possess fundamental skills to manage the patients safely throughout their disease cycle. And at most, we still need to continue to make sure that the basic surgical skills are maintained in these residents. And this is from Tom Nagoyan from Texas. I borrowed his, when he wrote this on the paper at JTCS in 2019, recommending skill sets of surgeons to acquire in transcatheter valve therapy, including pre and post and intra skills. I believe that surgeons must actively involved in patient selection, case planning, and post-op care, as well as able to identify patients who would benefit from not just surgical and minimally invasive and hybrid, but also transcatheter interventions. Not just doing procedures, but I think they need to learn to have the ability to interpret multiple cardiac imaging modalities that we have to face with these patients, including pre-case screenings and performing the transcatheter procedures, including how to interpret fluoroscopy, echocardiographic findings, and computed tomograph findings. Unfortunately, the challenges come because of the lack of access to formalized structural training. There are catheter-based elective rotations, but remain highly variable among programs. Rotations usually are inadequate to gain full proficiency in transcatheter technology and the techniques. These are basically up to 40 non-certified structural heart fellowship for interventional cardiology in the United States across the country. Unfortunately, for cardiac surgical trainees, there are only 10 that I could find across the United States, including Brigham, Emory, Houston Methodist, MedStar, Washington, Baylor, Plano Hospital, NYU, and UPenn. University of Texas is the only place that actually has 2 fellows. All the others have 1 fellows per year. And then the University of Texas introduces 1 to 2 year program. University of Virginia, again, 1. I'm not quite sure. I know Columbia started, but I'm not sure how many or how many years of a training. Coming north of the United States, the state of transcatheter aortic valve implantation training in Canada was looked at during the cardiac surgery residency program. And this was reported in 2017, and it's a web-based a survey to all Canadian cardiac surgical residents. It's kind of easier to do in Canada because we only have about 92 residents across country and only 12 heart centers that train the cardiac surgeons. And of all these, we had about 85 to 90% of these programs respond to our study. But we felt that this was still a broad representation from across Canada. Only about a quarter of program directors reported that their residents actually had access to TAVI simulation program or training. Most of the residents and most of the program directors agreed that TAVI was important to trainees' future practice, obviously, but only about two-thirds of residents and two-thirds of the program directors agreed that TAVI should be focus of fellowship program rather than just in the residency training. And they all perceived the barriers to TAVI training as lack of interest from the interventional cardiologist to teach surgical residents, that they are in constant competition with the TAVI fellows, mostly cardiology fellows, and there have been lack of formalized training time that's given to these resident training. Cardiac surgery in Canada is now a 6-year program coming out of medical school rather than going through general surgery residency and going up. And I apologize, I didn't realize the screen was small, but the program director's response and role of residents in TAVI is summarized here, but the question is, how often do your residents perform the following aspects of the case? And they talk about all these options. The problem is frequently and always is almost nil in every training or every response we got in Canada, which is a sad state. The majority are either never or rarely. The expectation of resident training in TAVI procedures vary widely between Canada and United States, obviously. In United States, the expectations are very specific. They say that at the end of your training, you need to do 5 TAVI procedures as a primary surgeon or a primary operator now that it's combined, and that they do 10 TAVI assistants as a first assistant, and that they need the so-called ACGME curriculum certification. In Canada, at the Royal College of Surgeons and Physicians of Canada, the objectives of training in the specialty of cardiac surgery is pretty vague, unfortunately, regarding the amount of time and the specific content of TAVI training. I think that we need to expose the cardiovascular residents to the heart team approach more so, and integrate the residents into the heart team culture, including the exposure to cardiologists, the imaging, the anesthesiologist, the cath lab, cardiac care unit, etc., and at the same time, ability to experience the broader base of cardiovascular medicine, to develop the relationship with physicians across the medical spectrum, especially cardiologists, and to cultivate program for shared decision-making and collaboration. The consensus from Canadian program was that the fellowship in transcatheter management, which should be at the fellowship level rather than the residency, including clinical decision-making in valve clinics, shared decision-making with the patient, skills in diagnostic imaging, as we talked about, intra-procedural imaging skills, procedural skills, obviously, along with management of complications and post-procedural care, in order to while maintaining the cardiac surgery skills. In conclusion, surgical trainees require a formalized and structured curriculum to obtain the necessary skills for transcatheter techniques, and only the leadership in the programs could do this. Along with competency in the open surgical techniques, one should prepare our future young cardiac surgeons and cardiovascular surgeons to be versatile in all aspects of caring for those patients requiring management of structural heart disease. We don't want to miss the boat. We don't want to become extinct, and we probably never will become extinct, but we certainly want to get on the same boat and maybe a faster boat in future. Thank you so much. I'm sorry.
Okay, the next speaker will be Mark Auditorium, and his topic is how to publish your research in a leading journal. Okay.
Thank you, ladies and gentlemen. The topic of my talk was really intended to another audience. Now I find I will be preaching to the choir how to publish your research in a leading journal. This is a topic I was often asked, and I just mentioned my conflict of interest being in editorial work now for 20 years plus. The fact becomes that when young people look for an advice, you must realize that it is very difficult to publish in a good journal. New England Journal of Medicine editorial is probably the highest impact factor in our field. It rejects 69% immediately because they do not fit to the program. The another 28%, 26% are rejected. So altogether, only less than 5% of the submission to New England Journal will have a chance, not will be published, they have just a chance. So it shows how difficult it is to guess the material there. Looking, for instance, at our own journal, European Journal of Cardiothoracic Surgery in blue, has a rejection rate in excess of 80%, about 82% now recently will be rejected. And our other journal, Interactive Journal of Cardiovascular and Thoracic Surgery, is also reaching now 30% acceptance ratio. So it is difficult to get published. So I think the rule number one, this is again meant for young people, it must be trustworthy and originality of the submitting material. And this must be repeated again and again, because there is a worrisome trend in scientific publishing that a growing number of papers must be retracted. They must be retracted because they are not inexact or they have been copied. For instance, this National Association of Science data showed that the plagiarism, duplicate publication, or race fraud are three major reasons for the papers to be retracted. The problem is so big that there is a World Conference of Research Integrity, and this takes biannual. And there was one was in Amsterdam, and it is very interesting to read the abstract book. The problem of untrustworthy publication is really existing, and it has to be addressed. The higher impact journals showing impact factor on the left and down is a retraction index, showed that the higher impact journals like New England Journal and Nature and Science will have a substantial number of retractions, about 2.5, more than 3%. Some of them must be retracted because of various reasons. So the higher impact factor, the editors are more strictly dealing with this. There is a organization, I don't know how many of you know about it, it's called the Retraction Watch. And this is a group of highly distinguished editors which watch the literature for retractions. And you will find that a Japanese anesthesiologist Mr. Fuji had a record of 180 patients, papers being retracted. Some of them have found that the patients never existed, they could never be traced. And the second one is Mr. Bolt, Joachim Bolt, was professor of anesthesiology in Germany and in Ludwigshafen. And he was praising the product for the plasma expander, and this plasma expander was loved by our anesthetist, and the patients were bleeding after surgery. They would implant, by the beginning of bypass, you put plasma expander and there was no drop at the beginning of cardiopulmonary bypass, but afterwards they bleed. And they told me that it's impossible, you are doing a wrong work, you are not doing a proper hemostasis. Look at the papers by Bolt who show that there is no additional bleeding. Dr. Bolt is now in jail because of his continuous cheating with the publications. So these highly respected editors do scan the literature for retraction, and they publish it every couple of months. You have the new update of the Retraction Watch. The most important condition for the publishing in a high-level journal, of course, is the novelty of the materials. What do you consider as the novelty in cardiac surgery? For instance, you don't have to develop a new technique for transposition, but a modification of a new technique. For instance, aortic valve reconstruction, there are numerous modifications which always find a place in literature. Or improvement of an accepted technique, for instance, subclavian versus femoral perfusion in acute type A, or therefore the consequences thereof. Or, for instance, a new analysis of the already known material. For instance, looking at the patency of coronary bypass grafting as a function of the disease of the stenosis of the vessel. That's one of the interesting fields. Or new relations, male-female, or always a good meta-analysis. The meta-analysis have taught us a lot about OPCAP. And OPCAP finally failed in the long run because of the meta-analysis of the trials that shown the inferior long-term results. When you try to publish it, one essential advice I can give as editor to avoid plagiarism. And plagiarism is defined as stealing or copying from other publications. It is very easy to do today because you have all the papers in electronic form. You can quickly download it. But there is a system which editors use. It is called Authenticate cross-check. In Authenticate cross-check shown here is shows you in red color or in violet color, will show you which parts of the submission are copied. And they will show you here on the right from where it was copied. And then it will give you the total index of 33% of the material is copied. Or this is, it comes across my desk very often, and it is obvious that cheating is nowadays very easily detected electronically. The one rule which should be always given to the younger colleagues, and it is even now mistaken, you get submissions with a lot of results. The essence of science is not to measure it, but also to present, to analyze your results after presented. There is an immortal saying by Henri Poincaré, the famous French mathematician, that the science is built of facts as houses of stones. But the collection of facts is no more science, and the heap of stones is a house. So analyze your results, just not publish the data. One must be very careful of overdoing the statistics. Significance in correlations can be totally meaningless, although they might be mathematically correct. Nowadays, you find in the literature more and more papers warning about the problem with the p-values, misconception of the p-values, and even coming down to Mr. Ioannidis saying that why most published research findings are false. And he says that, for instance, the significance ratio could be not 0.05, should be 0.001 as a standard for scientific reporting, which we are far away from that now. There is an American statistician who makes fun of the correlation ratios. For instance, you can find a perfect correlation with the number of highway deaths and the lemon imports from Mexico. And when you work with the statistics, you see that this correlation reaches R square of 0.97, which is very high degree of statistical significance, but it's totally meaningless. And now there are jokes being done by that. This is, for instance, random medical news from New England Journal of Incomprehensible Gobbledygook. And it shows that looking on the left, when you're looking, for instance, at stress or age or sex, will change the various conditions, and it will influence in a particular group of rats, of males, of females of certain age. And this continues. You find this about the red meat. The controversy has been going all over the place. So the people are making jokes of the scientists. There is in very good journals you will find, for instance, I have copied it from a recent paper, red blood cell transfusion as a predictor of death after surgery. Mathematically and statistically, it's correct. The patients who received blood transfusions have a higher mortality and even higher later mortality. Still, in my opinion, it is a nonsense. The patient didn't get blood transfusion just because somebody decided to have transfusion. They had a blood transfusion, they had a very, very difficult operation, and due to this difficulty of the surgery, they received transfusion, and even because of the difficult operation, they have higher later mortality. So the rule is association does not imply causation, and this should be stressed again. I have summarized here my own editor's alarm signs when I'm looking at the submissions. If it is a single surgeon series, I always question if it is a patient selection. And when it comes to my journals, I request a comparison with the unit statistics, because it's very easy to find good patients to perform either your OPCAP or your aortic valve replacement with a zero mortality, but it is not representative, it is just a high selection. One trick which I've seen again and again is looking at the other trial dates. For instance, people are reporting the results from March 2011 until November 2014. Why November? Why March? It should be full year. Obviously, they are omitting some cases which did not fit in their theory. They had some mortality before and after. So this is a warning sign of the odd trial dates. If you look at non-consecutive patient series, they say we did a series of tricuspid valve repairs in a patient with, say, lower atrial pressure, female sex, or whatever. Obviously, they are dropping unsuitable cases. And a very common error is reporting selecting subgroups, for instance, age less than 70 or normal left ventricular ejection fraction, then you immediately get a much better result. That is a way to improve your results. And the final strong editor's word is a follow-up. The follow-up is difficult to achieve. It takes a lot of work. It takes a lot of research nurses, which you might have. But the low-frequency event, for instance, looking at the mortality after aortic valve replacement, you will have a mortality, annual mortality of 2 or 3%. If you have your follow-up adequacy is less than 95%, you could be missing really the important patient, the patients who died. So your results will be meaningless. So to summarize, I think that the best chance of publishing in a leading journal must have the original, innovative, and properly analyzed material, and it should be honestly reported. Thank you very much.
Thank you. Thank you. Is it this one? Yeah. Next one is by Dr. Jawali. The topic is off-site cardiac surgery, increasing volume and penetration in cardiovascular and thoracic surgery. Dr. Jawali.
I'm from Bangalore, India. I'm talking about something different. Good surgeons are born if there are enough cases. Cases are dropping. We, in India, in Bangalore, approximately the this paper in 1995, nothing much has changed in our side of world. Approximately 4,000 cardiac surgical centers in the world with a striking maldistribution of access. CVT deaths are now 17.5 million. Majority of the 4.5 billion people, of which a large number also stay in part of countries like mine, 87% living outside North America, Australia, and Europe, or the affluent slice of the Southeast Asia, Middle East of Asia. If you exclude the tiny slices, then they have a very low or no access to cardiac surgery. India, 650 cardiothoracic centers for 1.3 billion people. It's about 1 per 2 million people. North America is 1 per 120,000. Africa is 1 per 38 million. And Asia at large, the non-affluent, is about 25 million per one center. The city surgeons in North America and Europe are 28 per million, India 2,000 per 1.3 billion, that is 0.6 per million. And globally it is adult 1.64 per million and pediatric 0.522 million. Globally, 15 million children die or face majority morbidity due to potentially treatable cardiac anomaly. Cardiac surgery is not a priority here for governments. The bureaucratic indifference is because there are other priorities. Poor governance is a public health hazard in most of these countries. If you look at the cost of the surgeries, again, it is so variable. In my place, which is quite eyeball to eyeball to anybody else, because we are private people, a CABG, if it is taken as a product, then all the cohorts of a CABG, the patient walking out on the day of discharge, I would take him as a product. My product might cost 5,000 or 7,000 US dollars. And if you go the same in one of the, some of the higher Western centers, it might be too much. The junk coming out of the theater may be 2 sacks in my theater, and in some other theaters there may be too many sacks. So this disparity. Another paper, Sub-Saharan Africa. There were 3 models because there were no surgeons there was no proper centers. There were 3 models, especially Ghana. In Ghanaian German model with a senior local consultant surgeon, like somebody was trained in Belgium and went back, was thought to be a game changer. Surgeons visiting for a short period to perform humanitarian surgery. Again, it was thought that it will change the game. And the third was expatriate surgeon on a contract basis to develop the cardiac programs. Actually, all these 3 models failed. Africa, the surgeon to population ratio, I told you already. In Western Africa, only 3 independent centers, and Ghana, Senegal, and Cote d'Ivoire. The average number of operations performed in these centers are very minuscule and insignificant. Only 2 other sub-Saharan African countries still have open heart surgery done with some frequency. South Africa is an exception. You cannot take it into that. So if you look at the world, the whole of Africa is such a huge mass of people and land. And now the violence is abating, democracies are strengthening, affluence is rising. So this is a very different ballgame. And look at the war-torn Middle East, and it's the same story. In India, everything is so mal-distributed. In China, there is so much of mal-distribution. Developing world, some realities. The feel-good concept of international community has only been a feel-good concept. International monetary aids have made a minuscule change. Reasons are very well known, I don't have to cite. Fortunately, in most of these countries, except a few democracies have been stabilizing, I just now said that, self-help is the only way for growth of cardiac surgery here in all these countries. Surgeons should be the part of the solution and not part of the problem. We cannot be bureaucratic, we cannot be citing all kind of examples. This paper, those lines only would mean in simple English, outcomes and success of a program is dependent on the surgical competence and overall leadership capability of the lead surgeons. And the chances for the youngsters to do that are shrinking day by day. They have less cases to do. They're not thrown into leadership position. There is somebody else to take care of that. So let me discuss India as a sample of the developing world, and the same thing could be applied to everybody. I'm one of the seniors, so I was involved in the thinking process. Every state of India is as different as the different nations of the Europe. India is a paradox ranging from brightest white to jettest black. cardiac surgery, unequal distribution, inadequate penetration, poor, very poor insurance coverage, only 3%. Now the government is coming up with certain frugal insurance covers, but that is a different story. Majority pay out of the pocket, incapacity to pay out of pocket for the larger population, delayed or no diagnosis in multiple pockets of India, several severe maldistribution of cardiac surgical support staff, poor funding for healthcare, especially cardiac surgery. Solution, the bright white spots need to help the black and the gray spots and leaving the government behind. We can't be waiting for the governments. Local innovative ideas that are applicable to other developing countries. Let me focus on 3 areas of personal experience because I was involved in all of them from last 4 decades. A, public-private partnership for micro-insurance schemes to increase the numbers of cardiac surgical. A poor alone is helpless, but poor got together can be very powerful and they can take care of their problems. Creation of centers of excellence for training with little or no government aid because there can be a PPP model and we have evolved some models which are excellent. Creation of, my state is the red patch on Indian map. Creation of, the capital is Bangalore. Creation of business models for off-site cardiac surgeries, to enhance, there is local models and international models, to enhance the penetration and the volume of cardiac surgeries. And the number of, increasing the number of trained people. If somebody goes to a center in Belgium and comes back, only he has learned. But the Belgium goes to that center, everybody learns. The earnings and the interest of the surgical team. If the surgical team to the lowest, their earnings starts dramatically rising laterally from what the hospital can do. And also, they feel more proud, they develop certain leadership enjoyment, then this would be a different thing for their interest. The 2 models that I built one was for Basra in Iraq, in the southern area, which is completely Shia. And in my state, Karnataka, in the north, I'm in the south, a small place called Bijapur, which is a rural place. I had a friend who had a cath lab in a small nursing home. And so we said we will take that as a sample. And in Basra, there was a teaching hospital called Al-Sadr Hospital, which had an infrastructure, though frugal, for cardiac surgery. We made an MOU with the governorate, and we said that we'll take this as a model. And we put a rota. I have 4 centers in Bangalore. I'm the chairman. And we have multiple cardiac surgeons, senior and junior, and the junior most level. But everybody is postdoctoral. And so we put a rota. In the beginning, I went everywhere at least for 4 times, and I lubricated and created an Indian kitchen there, created things like that so that my nurses could go safely and have a rota. So it was a win-win business model because locally the patients got operated locally without expensive harassing travels, especially in these Middle East countries. Less expensive, and it's a local center and its manpower got trained very rapidly and enhanced its local capabilities, enhanced local branding mileage for that hospital. And the local politicians, local bureaucrats were very happy because they could happily take free of cost the mileage out of it. And we didn't mind. Mother institutions at Bangalore, increased flux of complex and or rich patients. Incentive, a lot of these countries are very corrupt and the government officials actually have a lot of money. My center was happy to help me because all those people started coming to my center to get operated. And a novelty of experience for the surgical team members who were on the rota. And I saw that the children became men and women very fast. It may sound very odd and very funny to people coming from affluent countries, but this is the reality of the majority slice of the earth. Their sense of rising stature, role in improving countries and institutions, and their own image was outstanding. Surgical team, there was a lateral financial growth apart from the regular, and so it became a good business model. I'll just break down those statistics. If you look at these pictures from Iraq, this picture here in the corner, my team members at the celebration of the 500 case, we got down and we saw that on the road there were posters. And my team members were very proud, apart from whatever they were doing. They felt that they were raising their country's flag with pride. And so in 7 months of operating time, we had done, in the initial period, 478 cases, which was quite a lot for a for Gulf countries because these kind of numbers are not known. And then that was, it included even aortic root replacement, all that. But we were very super selective. They were very simplest cases where we could look for 0% mortality, and most of the other cases, with the help of organizations and the governments and us and some of the patient families, patient could come back to my hospital. But also, that would mean almost 70% of the lot, though they were simple cases. These 2 slides, I took it from my talk at Leipzig, Dallas meeting, because they wanted me to submit this to the plenary session. See what happened before we went there in Basra and what happened after we matured that center for some time. The local surgeons, the green, were doing hardly nothing. And after we went there, they were doing a lot under our supervision. And afterwards, when we were not available there, when we were not visiting in that small time, and later on we visited, in my absence, they were doing so much. So the local capability started rising, maybe for simple slides, but simple slides is more than 50%. The cases treated in India, my hospital was happy because before 14 and before 2014, the numbers that my hospital was enjoying was quite a lot. Then this small rural center in my own state, India, in 2 months of operating time, we had done 156 cases, which is quite a lot. And my city is in the south and that center is in the north. It's overnight journey. Off-pump, these were done in a very frugal manner. Most of the coronary bypass surgeries, for example, were off-pump, and the recycling was done heavily. In my center, we have a very standardized way of how we recycle. There is a dedicated committee for that, and we extrapolated those lessons to all these centers. So if you see the costs at the bottom were very, very low. The surgeons, anesthetists, right up to the ICU nurses and the technicians, if you could see the lateral growth on their financial earnings was quite significant in addition to whatever the hospital could do to them. So there were interesting compulsions. There were no full-time blood bank here. The blood products had to be procured and kept in the hospital. Unreliable cardiology, allied support was unreliable, leading to on-table surprises and post-operative management. So it was like visiting our past. But that made some tremendous difference to my youngsters, boys and girls, because they developed a sense of ownership, sense of leadership. They grew up very fast. Post-operative management done with extensive and effective use of WhatsApp and Skype, because somebody would sit in Bangalore and would guide these people very closely, because now it's so simple. Case and absolutely no money involved in that. Case allotment was done with a lot of planning, as only one temporary pacemaker was available. So cases with high chances needing one were done at the last case of the day. No complex valve repairs, as no TE was available. Simple MV repairs were done under epicardial echo guidance. No bioprosthesis in Iraq, so the cost was not covered in micro schemes in India. So we had these interesting compulsions. So to train on anticoagulation took a lot of patience. There are no complex pediatric surgeries. We were all bringing them back. But the non-complex cases, the number was quite big. Morbidity, no major morbidities, 2 cases of superficial wound infection. These patients have a good immunological, robust nature, and this single surgeon was operating from skin to skin, so the disciplines were different, and so outcomes were very good. None of the patients had deep sternal wound infections, possibly due to the single surgeon attending the entire process, robust immunology in these villagers. Only one patient had post-operative CV stroke, which fully recovered later. Average ICU, because these aortas were not bad and the patients were pretty young. Average ICU stays were 3 days, because most of the patients we erred in managing ICU and not daring to send them to the wards. About 11 patients, 2% required de-exploration, all was for bleeding. Blood transfusion rate was 23% with 1.9 packed red cells per patient. 3% CABGs needed post-op IABP support. Mortality in 7, 1 was MVR due to sepsis, 1 MVR due to severe low cardiac output, 1 CABG AVR due to severe low cardiac output, and VSD plus subaortic AS was due to fulminant pneumonitis. The other two model things, I would just quickly go. In my own state, we started this Yashaswini Cooperative Farmers Health Scheme, where every farmer, we asked him to just chip in a little bit, and the annual premium of $4.6 US and $10.9 US for the urban families. Screening camps by network hospitals at a native towns, end-to-end solutions. 100 million people are in my state, and a lot of them are poor. So, you know, the payouts were like this, very frugal. They ranging from $1,250 for a CABG to any complex pediatric surgery, $1,250. But because the mass is so large, by insurance economics, it worked out. The outcomes, total surgeries from 2003 to date are 1,500,000 people were operated and 136,000 have been cardiac surgeries. The moral is poor people in isolations are weak, but together they are strong. This was a public-private partnership scheme. Another innovative suggestion by the surgeon to the government was, it is still awaiting, there are 350 million mobile users. If they pay additional 30 cents per month, 600 types of surgeries can be insured for them in 650 networked hospitals in my country. This was another godman called Sai Baba, who attracted, and in our part of the world, people are very religious, Catholics, Hindus, Muslims. So people would be willing to pay for religion. And from that, something like this could be built. In my city, he built 2 hospitals, totally free. A lot of people from the Western world come on a rota to do free service and free operations. And you can see in these 2 charts, there are mind-boggling numbers that have been achieved in a cashless hospital like this. So you combine PPP, you combine the religious fundraising capacity of the people, and things like this could be born. Now this chain of Sathya Sai hospitals is spreading over India. And in Raipur, in the north, we have India's finest pediatric center, but governed by them, cashless. So in my city, on a PPP model, I went there in 1984 and I built this, and then later I resigned. But today, if you look at these charts, the growing number of cardiac surgeries, and the people pay only for the disposables, and the state pays for the non-consumables. So this works out very fine. And this is an autonomous public-private partnership institute. It has got now 21 seats for postdoctoral training of cardiac surgery per term, and 28 seats for cardiology. And there are, for prevention, mass yoga camps run by people whom we stimulate. And actually, if nothing, at least people learning yoga and, you know, and then taking care of in the city to continuance of those camps does something. Cardiac surgery in a large part of the developing world is stagnant or growing too slow and requires non-Western out-of-box solutions. Thank you.
Well, thanks very much. We're actually out of time. Can we allow 1 or 2 quick questions? Any urgent questions? Well, then it only remains for me to thank all the speakers and thank you for attending. It was actually a very interesting session. Thanks very much.